Welcome to ARI 2024, Alicante Refractiva Internacional. This is the session of clinical cases with a special interest, and this is an honor for me and a privilege to present you Professor Saader Hannush, one of the most experts all around the world of cornea, cataract, and refractive surgery. And thank you very much, Dr. Hannush, for staying with us, for your commitment with education, and a privilege to learn from you how to manage the clinical cases that you are going to share. Thank you very much.
Thank you, Dr. Hessa. It's a pleasure to be with you. And I know you're doing great things, not only in Sevilla, but all over Europe and the world. So thank you.
Whenever you want, you can share your screen, and then we will learn about your clinical case, please.
So welcome, everyone, to ARI 2024. It's a pleasure to be with my host, Dr. Hessa from Sevilla. And today I'm going to share with you one of the banes of our existence, one of the things we fear most after doing DMEK, decimal membrane endothelial keratoplasty. And that's a case of an interface infiltrate that developed 6 weeks after surgery. My only disclosure is I consult for COA. They are the makers of a Rho kinase inhibitor. So this is a 76-year-old gentleman who presents to us 3 years ago with decreased visual acuity in both eyes, 20/60 in the right, 20/70 in the left. He has Fuchs corneal endothelial dystrophy and cataract. He underwent uneventful DMEK combined with cataract extraction and intraocular lens implantation on the left eye in 2002, was so happy he wanted the right eye done. His examination, as shown here, was basically significant only for the corneal changes in both eyes, confluent guttae and trace stromal edema, together with a cataract. The vitreoretinal examination was completely normal. So again, he did well with one eye, and this is actually the second eye that was done in late 2022. This is a basic technique that all of you use. I'm doing the cataract first, after emulsification of the nucleus, using a bimanual technique for cortical removal, and then implanting a one-piece acrylic lens. This is a hydrophobic lens in the capsular bag, stripping Descemet's membrane off of the recipient. We like to constrict the pupil afterwards to decrease the chance of the graft going posteriorly. And then we do an iridectomy with a 25-gauge cutter. The graft is injected into the anterior chamber. You can see here that it's upside down, so I flip it over. And then using the Derisimer technique, we are basically opening it up, and then we put our isoexpansile concentration of sulfur hexafluoride, and the case is completed. Patient did very, very well, was seen the next day, and I'm in the habit of doing donor rib cultures. I must admit I'm in a minority of people who do donor rib cultures. The question is, how do you do it when the graft has been given to you pre-stripped, pre-punched, pre-marked, and pre-loaded? Well, we ask the eye bank to send the donor rim, and we can culture that, and sometimes we can culture the storage medium. We know there's a 1.2% positivity rate in the donor rim. This is the work of Tony Aldavi from UCLA. And what's most interesting is that of those that are positive, again, only 1.2%, 11% of these patients will develop infection in the recipient, either a keratitis or an endophthalmitis. We don't know if prophylactic antifungals are helpful. That issue is still debatable. It was a big topic of the discussion this past weekend at the eye bank meeting and the American Academy of Ophthalmology in Chicago. 10 days later, patient is doing great, but I get this culture result. Scant growth of Candida glabrata. Obviously, I'm not happy. The question is what to do about it. Patient is doing great. As you all know, people differ on how to manage this. Many of us feel that something should be done. Otherwise, why do corneal rim cultures? If you're going to do cultures and they're positive, you're going to do something about it. So this patient was started on an oral antifungal, specifically fluconazole, 200 milligrams twice daily, prophylactically. Continued to do well, and then showed up at 6 weeks with this multi-lobed infiltrate. Here is the edge of the graft, of the DMEK graft. So this multi-lobed infiltrate in the graft host junction or close to the graft host junction, but certainly in the interface. We did anterior segment OCT, and as you can see here, there is a lesion in the interface at around 10 o'clock nasally. So we decided to start him to continue the oral antifungal, and the epithelium was intact. We decided not to use any topical antifungals, but watch him carefully. Again, this is debatable, and there are no good answers. This is how he appeared when that infiltrate was seen. He had a well-opposed DMEK graft to the host, but several small infiltrates, or a multi-lobed infiltrate, as we described it. So the question is, how do you identify the organism in the recipient? What are the approaches to getting an adequate culture? Is this a medical problem or is this a surgical problem? Some people feel it is medical. Some people insist the only way to cure it is surgical. And the only thing I want to point out to the audience here is that the infiltrate was, yes, it was in the interface, but very close to the edge of the DMEK graft. If it were purely in the host, outside the graft, you would have to assume it is in the anterior chamber and therefore technically an endophthalmitis. So we continued managing just with the oral antifungal, and he was doing great. 2 months out, he comes in with a worsening of the infiltrate, and the question is what to do now. And because of the worsening of the infiltrate, we decided to give him intrastromal antifungals and intracameral antifungals, but we withheld on intravitreal antifungals because the B scan was completely normal and he had an intact posterior capsule. Talked to our retina colleagues, and they said it's reasonable to watch him. So we went ahead. You can see the infiltrate there just at the edge of the DMEK graft. And here you see me injecting 50 milligrams of voriconazole in 0.1 cc's into the stroma. There's the injection. And the idea is to create a stromal blister right over the infiltrate. And then we injected it also into the anterior chamber. He was still seeing very well, but this is how he looked at the end of the injection. And we were very happy until this happened. So stromal antifungal injection, intracameral antifungal injection, and then this happened. And obviously when this happened, this is by definition now an endophthalmitis. So our vitreoretinal colleagues went ahead. The posterior capsule is intact. They did a vitrectomy, sent that specimen for cultures. It did not grow anything. They also did an anterior chamber tap with the same vitrectomy cutter, and they used the 25 gauge cutter to obtain a specimen both from the infiltrate and from the hypopion, but they did not separate these two infiltrates. So these two specimens. So those grew Candida glabrata. So we have Candida glabrata growing from the anterior chamber and the biopsy of the specimen, as well as from the vitreous, as well as from the anterior chamber, but not from the vitreous specimen that was obtained. So the decision was made at that point. Obviously, at the time of surgery, he also got intravitreal antifungals as well as anterior chamber antifungals to supplement the intrastromal antifungals that we gave. And now that we know that he has Candida glabrata in the eye, the question is it sequestered only to the anterior chamber and possibly the trabecular meshwork, or is it in the vitreous cavity, even though there was no suggestion of growth in the vitreous cavity? So we decided to observe him, and he cleared up completely after the injections in the vitreous cavity in the anterior chamber and the stromal injections that were done prior to vitreoretinal intervention. So we were very happy. But the story doesn't end here, of course. He decides that he has to go on a family vacation to Scotland. I said to him, sir, not a good idea to travel right now. We don't know how this is going to play out. He told me, Doc, listen, my family's from Scotland. I'm going to Scotland, and whatever happens, happens. So he goes to Scotland. We're very happy for him. He calls me from Scotland. Obviously, I gave him my cell phone number. He calls me from Scotland and says, Doc, I think we got a problem. Yes, sir, what's the problem? Well, I ran out of my oral antifungal, fluconazole, about 10 days ago, and my vision is much worse now. I said, did you change anything else? Obviously, we had stopped his topical steroids. He was only on some non-steroidal anti-inflammatory, and we also had him on cyclosporin topically for whatever it's worth as an immunomodulator, and maybe it has antifungal properties together with the oral antifungal. Comes back to the US with this picture, and not as bad as he was originally, but a new hypopyon. I called the retina specialist. I say, what do you think we should do? He says, I'm going to go ahead and give him another injection of voriconazole in the vitreous cavity in the anterior chamber. Let's keep him on oral antifungals. So we did. We restarted the oral antifungals, got 2 injections, cleared up completely, and I thought that was the end of the story. But then I decided to wean him off the oral antifungal by a little bit, from 200 milligrams of fluconazole twice daily to 200 milligrams once daily. And once that happened, the hypopyon returned, just by decreasing the oral antifungal. So this is the moral of the story here. Nothing else was changed between this picture here and this picture here, except reduction of the oral antifungal. So this is on oral antifungal. This is on no oral antifungal. And frankly, I've not experienced that in my career, but the explanation may not be that mysterious. Just summarizing, patient who had an uneventful DMEK triple, donor culture is positive for Candida glabrata, started on fluconazole empirically, nothing else. Patient developed an infiltrate in the interface. He received intrastromal and intracameral voriconazole, 50 micrograms per 0.1 milliliter, both in the stroma and in the anterior chamber. Got worse. A vitrectomy was performed, also an anterior chamber tap with a specimen from the infiltrate itself. Injections were given, antifungal injections were given both in the vitreous cavity and the anterior chamber, and the oral antifungal continued. Patient improved dramatically, and then the oral antifungal ran out. He developed a recurrent hypopyon. The antifungal was restarted only orally, no topical antifungals, no intracameral, no repeat intrastromals, and he resolved completely. When I tried to reduce the oral antifungal, because he's been on it for several months, and I'm working with his internist on liver function studies, making sure that he's not getting toxic. But once we reduced it, he flared up again, and then we went back to 200 milligrams twice daily, and he cleared up completely. Here are some references for anyone who wants to look at them. And I want to thank our chief resident, Dr. Colin Richards, who did so much of this work for the visiting professor, Ellen Kuhl, who came in from Bascom-Palmer last fall. I'm happy to take any questions from you, Dr. Chessa. Dr. Richards decided to go into vitreoretinal fellowship, hopefully not after this case. Thank you very much.
Okay, incredible. How long is the patient with the fungal infection? 1 year?
So from the beginning, from the first appearance of the fungal infection, that was in November of 2022. So we are now 2 years out, almost 2 years out.
And he needs also the oral antifungal. He needs to avoid any recurrence, right?
Well, that's my hypothesis. I don't know that I'm right, Maria. I don't know that. But we once we stopped it, because he ran out of it while he was on vacation, that was the only change. And once we reduced it, and that was the only change, both times he had recurrence. So the question is, where is the nidus of infection? And what can be done about it other than the systemic antifungal? And he has said to me, he's happy to be on it, and his internist is okay with it indefinitely. Obviously, you're asking that question because there are other alternatives. We can talk about them if you have time.
Exactly, because another alternative, maybe you have asked yourself, if the fungal have the capacity to survive in any tissue, and maybe it is in the interface between the DMEK and the posterior stroma of the cornea. Did you think to remove the DMEK at any time or not?
So there's no doubt, and there was not enough time to go through all of this, obviously, but there is no doubt that surgical management is one of the options. So many people, for example, before the advent of penicillin, you developed a terrible injection in your lower leg. They amputated your leg, right? So this has been around for hundreds of years. So clearly some people are strong advocates of replacing the DMEK graft or just simply removing it and injecting intracameral antifungals, or doing a full thickness graft to incorporate that whole area. But now I can tell you the interface is completely quiet. I am not suspecting an infection in the interface at this time. I'm suspecting that it's somewhere else.
And it's surprisingly how well is the DMEK, because DMEK works perfectly. Despite all the episodes of recurrence, cornea is extremely clear, and the function is perfect.
Yeah, it's remarkable. The endothelial cell count right now is 1,100 cells per square millimeter. And ironically, it's a higher cell count than the other eye, the 20/20 eye. So he doesn't want anything done. There's no way to convince him to have surgery. And he's had 2 experiences with decreasing the oral antifungal. He doesn't want that to be changed. The other things we thought about at this time is a series of intraocular injections. Because we think, unless you want to ask me, but we think it's living in the trabecular meshwork.
Yeah.
That's what we think is the nidus. And we considered a series of injections into the intracameral and intravitreal. And some people think that there's an antifungal called capsifungin, and to use systemic injections of capsifungin, we would have to start a PICC line, like we do with cancer therapy, and give him multiple injections over a period of time to eradicate it. If you hope to do it systemically, he doesn't want anything done. The patient is happy.
Thank you very much. It's an spectacular case, and one point is to have faith in the intracamerular and intrastromal injections of the antifungal, because the results we can see how have they gone perfectly. So thank you very much. Thank you for staying with us, Dr. Saader Hannush. A pleasure to stay here with you, and I'm sure all the audience will learn a lot from this case. Thank you.
Thank you, Dr. Chessa, for your kind invitation and for your collegiality and friendship over the years. Have a great meeting.
Thank you very much.
Bye now.